Welcome everyone to the Sunday night edition of our national webinar series. We're lucky enough tonight to have Dr. Chris Putnam. Dr. Chris Putnam had earned a Bachelor of Science degree in biology from South Dakota State University in 2001 and a doctorate in optometry from Pacific University in 2005. He was commissioned in 2004 as part of the Health Profession Scholarship Program, completed the United States Air Force Optometry Residency Program at Wilford Hall Medical Center, and was awarded the board certification in 2009. Most recently, Dr. Putnam was handpicked by the optometry consultant to the United States Air Force Surgeon General to help align the activities of all United States Air Force optometrists across 75 clinics in the Air Force Medical Service Strategic Vision, impacting $51 million project line, which provides vision and ocular health service to more than 2.9 million beneficiaries worldwide. It is a great pleasure. Chris is a great lecturer, and it's a great pleasure to have him here tonight. He'll be presenting excellent material tonight. Please give Chris his virtual round of applause. Chris, please take it away.
Outstanding. Well, thank you, Greg. I really appreciate that very warm and mostly undeserved recognition. So greetings virtually, everyone. So yes, I'm here in Qatar for the next few months. I've been over here for about 7 now, so the end is in sight. Tonight, what I wanted to talk about was the off-label medication use in primary care optometry. A wise man, and I'm sure everyone's heard the adage before that, the plural of anecdotes is not data. And I think a lot of times when we think of off-label medication use, that's exactly what we're used to, is anecdotal uses of different medications. So today, what I want to focus on is really the peer-reviewed medications. And so I want to use the evidence-based practice, the peer-reviewed literature that will help guide us to make those correct decisions for using off-label medications. As Dr. Caldwell mentioned, this has been kind of my journey. So I was awarded my PhD through UMSL. The Air Force has a Air Force Institute of Technology where you can be a civilian for 3 years and go back and do a graduate degree that helps support the Air Force line of operations. So I did my PhD in vision science at UMSL in 2015, and I have been paying the price ever since, so to speak. I will put my shameless plug for Air Force service. So if there is anyone online that has friends, family, kids, colleagues that are interested in either active duty service, Guard, or Reserve, please let me know. I will say that the last 16 years of active duty service have been very interesting, and I'd be more than happy to share some of my experiences. Just a quick snapshot. So from a humanitarian research and operational deployment, I've had a chance to see most all the continents. I'm still missing Africa and Antarctica, but hopefully I can check Africa off my wish list, because it looks like I will be headed there not long from now. But Antarctica is going to be a tougher one to come up with. Financial disclosures, this is a very simple slide for me. I have none. So currently everything that I'm looking at and everything that I'll discuss tonight is really just kind of driven by the research that I did while I was at University of Missouri, and a lot of the clinical practice that I provide in not only the Air Force, but also at the University of Incarnate Word, where I am adjunct faculty. So just a real quick look at the overview. It's a rather ambitious overview, and I'm very, very happy to make this more of a conversation and a less formal presentation. So if there's ever a question that you'd like to type into the chat box, or you would like to just ask verbally or with audio, please let Dr. Caldwell or Vanessa know, and I'll be more than happy to stop, break, and we can chat through it. You can see the second part. What we'll also discuss is going through each one of the medications, and we'll look for some of the off-label uses, but only those off-label uses that have supporting peer-reviewed literature, because I think that's the most important part to me, is to make sure that I'm bringing evidence-based practice to you that can enhance your practice within your own lives. And then I'll discuss one of the CSC cases that I had while I was in Japan, and how we use an off-label medication very successfully because it was our best option at the time. And so we'll talk about some of the take-home points, and then in summary, I'll try to wrap everything up underneath a neat little umbrella to talk about the most studied and the clearest use off-label medications. And I'm hoping that in tonight's discussion, we'll be able to almost redefine what off-label medication use is, because I think you'll find that off-label medication use does not mean you shouldn't use it. And in most cases, off-label medications are the current standard of care. And sometimes the FDA approval is not exactly what you're using it for now, but it has over time become the standard of care. And even within the randomized controlled trials, they even use off-label medications quite much more than you might expect. So we'll kick things off. I'm really just starting from the very baseline, going all the way back to either your undergrad or your professional training. Pharmacokinetics versus pharmacodynamics. Really, today we're going to focus on the pharmacodynamics. So really the easiest way to think about it is the kinetics is what the body does to the drug, and dynamics is what the drug does to the body. And what we're going to focus on is what the drug does to the body, primarily defined as its mechanism of action. And that mechanism of action, or MOA, that's the important part to really thoroughly understand for some of these classes of medications, because understanding that MOA and what it does and what its second order effects are can actually help you in your clinical practice decide why you would choose an off-label medication and how you would go about selecting the proper one. So we'll talk just real briefly about the FDA itself and some of the reasons why off-label use is here to stay and will always be with us. So the FDA approval process, I won't bore everyone by reading the slide, but the most important part to kind of see on this one is when a drug is approved by the FDA, it is approved in a very rigid, very specific left to right parameter. And you can see that there is a specific medical indication, and it comes with a dosage, it comes with the form, whether it's in a capsule, pill, oral, IV, IM, and the side effects that come from the randomized clinical trials, and then its chemical structure. And understanding the chemical structure of some of these classes is also a vital part of why you would choose an off-label medication. And so I thought this was an interesting study that came out. You're not having to read everything, but if you go down to the results, you can take a look that off-label medication use with strong scientific evidence had the same risk for adverse events as an on-label use, meaning that if you are using an off-label medication use appropriately for the right condition, its risk is the same as if you would use an on-label use for the same condition. And it does come with a word of caution that exercise caution should be used for off-label drugs that do not have strong scientific evidence. So I think that kind of goes without saying that the plural of anecdote is not data. So what I'll do today is there will be a lot of information on some of these slides, but I believe the slides I have sent forward to OEC and Dr. Caldwell and absolutely can be shared. So this is meant to be a reference slide deck for everyone here at home. So the FDA approval process, you can see some of the barriers to entry. And as you're reading through the barriers of entry, I think you can go down to the asterisks at the bottom. The treatments that have not gone through FDA approval process have demonstrated effectiveness and are widely used. And in fact, many of these off-label medications that we'll discuss tonight, some you'll know, and hopefully some will be new and introduced new tonight, but quite a few of them are standard of care. And you're going to notice that even if you feel like you don't do off-label medication prescribing, you're probably already doing off-label medication, because the conventional treatments, the standard of care that we were taught in clinical training and you've developed during your clinical practice is not necessarily what the FDA approved that drug for, but it's been widely accepted because that is what is clinically relevant and best for the patient. And you can also see that clinical trials reported in peer-reviewed literature are not necessarily always done under FDA supervision. So certainly they will have an informed consent document. There will usually be usually have what's called an IRB, or a institutional review board. So there are stringent safeguards in place to ensure that there is not undue risk to the subjects in that study. But many of the drugs studied are not necessarily used just as the FDA prescribed. And so just a quick one, you can see if you do the math in your head, it's between 8 to 9 years on average to get a new drug in that FDA pipeline and get that new drug to market. So this can be a very costly, very time-consuming process. And as we'll talk about in some future slides, what can happen is if a drug that is currently off-label is used widely and accepted widely as a standard of care, there's virtually no incentive for any company to bring that drug to market under FDA approval because it's already widely used. And to spend all that time and all that money to bring a drug that's already used to market doesn't have that financial incentive you would need for many of the large pharmaceutical companies. And this one came out of Ophthalmology 2020. I just thought it was a very interesting graph. So as you look at this graph, I have not only the commercial, but also the generic names on the left. And that black line running right down the center essentially is the FDA approval date. So the dots to the left are all the studies that happened before FDA approval, and all the dots to the right are studies that happened after FDA approval. And you can see that when I first started researching this topic during my graduate days, I really thought of it as more of a static continuum. Like, that sounds contradictory, but a very linear function of here is when the studies were undertaken, here is when the results came out, here's FDA approval, and then it went to market. But you can see that that is not the case at all. And as I mentioned, many of these studies take place outside of FDA oversight. So although the drugs are being used appropriately, they're not necessarily being used under an FDA auspice. So you can see that there's quite a bit of research that goes into many of these drugs that are both on and off label and multiple indications. Then that's why that peer-reviewed literature, and I'll show you a very nice reference at the end that is completely free, that does a meta-analysis and a systematic analysis of all the similar studies, so it can help you make a better informed evidence-based choice. So we'll talk about the proper use of off-label medications. And really, if you get deep into the literature, there's really 4 overarching reasons or justifications, if you will, to use off-label medications appropriately. And we'll talk about investigational use, the informed consent, and then insurance carrier criteria. So really, as we probably have intuitively picked up, any use of a drug not listed on the label is considered off-label. So strictly speaking, if you are not using that medication, whether topically or orally or intravenously, exactly as the FDA specified, you are technically using it off-label. And so the reason that I put this out there is there are legal implications of off-label drug use that are really dictated by risk management. I think in optometric practice, most of the medications we're going to use, and the medications I'll share with you tonight, have a very strong safety profile and have been well researched. I think what this comes down to is when you get some of those, say, anti-carcinogenic drugs, when you get some of those new biologics, I think those are the ones that tend to have a little bit higher adverse events. So those are the ones you'd have to be exceptionally careful. So if your practice includes some of those cutting edge drugs, certainly this is something you practice every single day. So from an investigational use, this is the use of a drug in the context of a clinical study. So I think in primary practice or primary care practice, it's unless you are a research arm or unless you are a clinical investigation site, you probably don't spend a lot of time completing the investigational new drug or IND applications. But if you have ever worked in a site where you are an investigational research site, this is something that is not new to you. So this is just very clearly showing what separate parts that your investigational or your off-label use would have to follow. So this is one that has a very specific guideline for off-label use. Informed consent, this is one that from a medical legal standpoint, if it's one that you are concerned about and you are prescribing a medication off-label, this is just a very boilerplate sample informed consent form. Certainly this one you can take right off this slide and utilize and include in the patient's chart. You can make this in electronic form if you would like. I know at UIW and even within the Air Force, we'll always inform the patients, and we will make sure that the patients acknowledge and recognize that what we're using, albeit safe, albeit studied, is an off-label use. So that way you are open and honest in the discussion for why this medication was chosen for that particular condition that you are managing. So an insurance carrier criteria. This one, again, unless you're working in an advanced care practice that you're using the very expensive drugs that run between $2,000 to $3,000 a dose, or you will have to spend, 5 figures over a 12-month period to manage, that's where the insurance carrier criteria becomes a real big issue. But you can also see that to be prescribed and to be covered by insurance for an off-label use, you can see the two criteria. So it must be considered or may be considered medically necessary, which that's why you would prescribe a medication in the first place. So check. And then what you can also do is you can use one of those four on the bottom, or a qualified clinical research that appears in peer-reviewed scientific literature. And so that's exactly what I'm going to give to you today. So meaning that every drug that we'll talk about today and every drug that has a medical indication and is well supported with peer-reviewed literature, that checks both boxes for insurance criteria to reimburse or to compensate for that member. I will state in complete honesty, because I work for a university and the United States Air Force, insurance coding and billing is not my strongest suit. So I will take all the experts in the field to help educate me. If there is something that you've learned from your boots in the ground days, I would love to know more about this. But from what I can read through the insurance criteria and what we've used at UIW for some of the medications, as long as it's medically necessary and as long as there's a clinical research support for it, it meets that carrier criteria. So now we'll get straight into the drugs. And if there is one godfather of off-label use, I don't think there is anyone that has claimed the title except for Avastin. For any practicing optometrist or ophthalmologist, Avastin is the off-label use medication king. So everybody knows that originally this came from various cancer tumors, and primarily it was in colorectal cancer is where Avastin came to us. But the quote at the very bottom was given by one of the leading vitreoretinal surgeons. I didn't get authorization to use his words, so I'll just quote because they're not my words. Management of exudative conditions with Avastin has been embraced by ophthalmology without definitive guidelines from clinical trial data. If you think about that, that's should give you pause for a moment, meaning that the Avastin was used well before there was significant clinical data out there, but it was the best we had at the time. And because of its cost effectiveness, it allowed a portion of the population to receive that critical anti-VEGF care to help preserve the vision in an exudative condition and also prevent further damage in exudation. So I think you're going to find that in cases where there is a strong support from the optometry or ophthalmology community, you're going to see that a lot of these peer-reviewed, or excuse me, a lot of these off-label medications, before they have a significant body of peer-reviewed literature, you're going to see that that support, that groundswell, creates almost a standard of care, even absent of FDA approval. And so I think this one, again, it's an older study, so I'll point that out right away. But this is one of the reasons why Avastin will never be FDA approved, because there is no incentive. There is no risk reward for them to even evaluate. It's widely used right now for anti-VEGF purposes. And because essentially Avastin is nearly equal in both safety and efficacy to the medications for anti-VEGF that are being FDA approved for some of the wet AMD and some of the diabetic hemorrhagic maculopathy, you're going to find that Lucentis versus Avastin is not going to be FDA approved because there's no financial incentive for that. So you'll keep. This is a theme we'll revisit a few times in the future, because unless there's a reason, a financial incentive for those pharmaceutical companies, a lot of these standard of cares that are off-label will remain off-label. So it's a kind of a comfort level that you as a provider, you as a practitioner, just need to get comfortable with. So Dr. Caldwell, here's my very first polling question. Just to the crowd at large, have you ever prescribed a medication off-label?
And it's up and running, Chris. And
if we have any questions,
I'm going to make a couple comments just regarding some housekeeping while this is running. Someone asked if it was covered by orals in Florida. I don't think so. This is covered under pharmacology. I don't know the New Jersey. So this is, someone asked to be under orals. I understand New Jersey needs a lot of orals, but this has a PH, pharmacy. So I don't think it would be under oral, because there is an oral category. And then someone was asking about the clarity for Florida. I might have been confusing on it. This will not count for Florida. It doesn't matter about cameras on, off, or anything along those lines. Sorry if I created confusion. And then finally, I get to make a comment about the lecture, Chris, is that, I think a lot of people, as you go through here, are going to see a lot of medications and maybe surprised that they didn't even realize that they were using off-label, but off-label is not bad as long as it's, in a sense, the standard of care. 3 out of 4 people doing it, 9 out of 10 people doing it. It's just that the salespeople, when they come into the office, the sales force, they cannot talk off-label. So that's the key. If you want to get a sales rep out of your office, to start talking off-label usage of it. Now, the medical science liaison at the pharmaceutical companies can do that. So you just have to kind of know the pyramid or the employees at a pharmaceutical company. Sales reps always on label. Off label, if you want to do that, medical science liaisons are the MSLs. And there's your polling results.
All right. So what I'm hoping to do is, as we continue through this, I think that I'm hoping to actually get this to 100%. If I have a hope in tonight's lecture, I'm hoping that I can get everybody to 100%, because as Dr. Caldwell alluded to, I think you might be surprised that some of the, especially, I'll just, spoiler alert, 4th generation fluoroquinolones, you might be surprised at what you use 4th generation fluoroquinolones, essentially catafloxacin, moxifloxacin. It's FDA approved for bacterial conjunctivitis, and we use it very broadly for things like pre and post-operative, things like keratitis, corneal ulcerations, but that is not its FDA approval. It's widely accepted. It is the standard of care in addition to fortified meds, but you might find that you're using them off-label and you're just not aware of that. So we'll go through that in detail here in just a moment. All right, and let me close that down. There we go. All right, so let's get straight into it. And again, if there is any questions that anyone has, by all means, I love this to be kind of an informal sharing type of process. So I'd love to learn from you guys as much as I can help provide to you. So anything at all, if the spirit moves you, let me know right away. So what we'll do is we'll talk about anti-infectives. So it's going to include the 4th generations. We're going to talk about topical, again, Cyclovir, Betadine. I think everybody's familiar with that. And Dr. Caldwell must have read my notes ahead of time, because we're going to talk about Azozite. And that Azozite is a lesson in recognizing what you can market drugs for and what you can't market drugs for. And we're going to speak very specifically about Merck and some of the hand slapping that resulted from its marketing campaign of Azozite. So here we go. Here was that spoiler alert I mentioned. So if you actually go in and look for the FDA approval, and if everyone, I know everyone's got plenty of time, I'm sure, but if you ever have an interest, when you look up the FDA approval for any of these medications, you will get a PDF that has lots of handwritten notes. It will actually show you what the FDA approval company wrote in the margins, every note that was taken. You can scroll through, and a lot of it is scanned in original documents of how that approval process went down. And so when you look at the 4th generation fluoroquinolones, its FDA approval is for bacterial conjunctivitis. And so you can see the mechanism of action there. Clearly, that's why most of us, myself included, will use this for a relatively uncomplicated keratitis or a early stage, or what you might say mild corneal ulceration, because we're very comfortable with its broad spectrum, not so much maybe in the gram-positive, but its broad spectrum effectiveness that covers all manner. And so in a lot of cases, from a primary care standpoint, it prevents us from having to do a swab and culture. It prevents us from having to spend that extra time making a clinical decision while that patient's condition isn't resolving. So a lot of times we're going to use 4th generation fluoroquinolones for a keratitis, but that's not what it's FDA approved for. And so just a quick example here, you can see that the 4th generation fluoroquinolones, if you go all the way to the bottom, the rationale for why essentially ciprofloxacin and ofloxacin is the 2nd generation and levofloxacin is the 3rd generation were replaced a little bit by the 4th generation. A lot of times it's because that 4th generation, it was requiring a mutation at 2 separate loci on many of those bacteria. So the staph, the strep, it was requiring almost a dual mutation to escape the spectrum of effectiveness of the fourth generation. So that's why they found that the fourth generations were a little bit more effective. They had a broader spectrum, and that's why they're so very widely used in a primary care optometry setting. So we'll also talk a little bit about Cyclovir. So if anyone has treated a herpetic keratitis, I would say that the United States Air Force, I can't speak for the other branches, but I see more HSV that doesn't look like the HSV we learned in the Air Force than I have anywhere else. And I think a lot of that is sometimes even like a zoster in that little bit older population, stress, fatigue, immune suppression. You'll get a lot of these patients that will roll in and it will pop up and rear its ugly head. And once it starts, you really want to get on top of that. And for those older providers in the group, which is me, if you're used to the old treatment where you were using a drop 9 times a day and you had some significant cytotoxicity from the original antiviral drop, the Zirgan is actually relatively targeted. Actually, it's highly targeted for herpetic DNA. So it actually works very, very well to inhibit viral DNA replication by selective inhibition. But the reason I bring this up is because also in my clinical practice in the Air Force, we get lots and lots of adenoviral conjunctivitis. And a lot of times, if you're not exactly sure and it's a viral condition, it's not bacterial, a lot of times we'll use Zirgan off-label. And so this is the reason that I like Zirgan as an off-label, is because it's specifically FDA approved for herpetic keratitis. But even if it's adenoviral, even if you're using that point of care adenoviral RPS system, Zirgan is very effective because it has significant inhibitory activity against a number of the serotypes. So anytime you're thinking of a PCF or an EKC, Zirgan is a very nice option. And Zirgan can be relatively expensive as a standalone medication, but because it meets those insurance carrier criteria that we talked about, it's medically indicated and there's peer review for it. You can, in fact, submit an insurance claim for Zirgan for an adenoviral conjunctivitis. And this is a really nice advent. Instead of being that palliative care, we can actually give the patient something to knock down the viral replication and speed up the healing process. And another one, the Betadine Protocol. I know this has been out there for a long period of time, but I want to make sure it's being all inclusive. But you can see that its FDA approval is very specific. So it's the periocular preparation and irrigation of the surface, and it's in the prevention of skin wounds and infection. But you can also see that a lot of times if you have a raging adenoviral, especially EKC, we have something at the Air Force Academy that the cadets in their first month of training have to go to what's called Jack's Valley. And Jack's Valley is a high stress, low sleep environment, and everyone's crammed into sleeping quarters. So you will get what's called Jack's Hack, and you will get a large number of people that will come out of that training environment with a viral condition, to include an epidemic keratoconjunctivitis. So a lot of times we were almost like an assembly line treating people with a Betadine protocol as they went down the line, certainly anesthetizing and then treating with an anti-inflammatory drop to get them out. But it would really shorten the course. And suddenly now I don't have an infectious individual running around that campus for weeks afterwards. So I think the Betadine diluted down, and we'll talk about that right here, that Betadine diluted down to essentially a 2.5%. You anesthetize the eye, you let it sit for essentially 10, 15 seconds. There are different protocols out there. But if you look at this treatment study that looked at 2012, it successfully relieved the ocular discomfort. So you're not only making the patient feel better, but you're also speeding it up within a single week. And so essentially 80% of the study group here did better using the Betadine protocol than no Betadine at all. So just something to consider within your clinical practice, especially if you're, you know that it's adenoviral, you know it's a viral component and not a bacterial component. The Betadine protocol can be very effective. And then here is the one that I want to talk about for a moment, because I think this is going to be a very good example of the FDA approval and what marketing can be and what marketing should not be. So you can see that topical azithromycin, or Azozite, FDA approved for bacterial conjunctivitis. And it was the first commercially available ophthalmic formulation. So that's what made it such a game changer when it first came out. And you can see this mechanism of action. So it's interfering with protein synthesis. And the big thing that it came off for was the Durasite. So it was the vector that the azithromycin was contained in, that it held it against the corneal surface. It allowed greater contact, thereby greater efficiency. But what was happening was there were a lot of individuals that were noticing that metalloprotease, the MMP9 inhibition, was also occurring, and they were also getting some decrease of the inflammation on the ocular surface. So it was starting to be marketed a little bit for blepharitis. And so you can see this came out in 2008. So again, a little bit older study, but you can see that azithromycin in combination with warm compresses was a significantly greater benefit than warm compresses alone. So when studies like this were coming out, what you were finding was Azozite was being, hey, it's really good for bacterial conjunctivitis, but if you get somebody with a posterior blepharitis or just a general blepharitis, you could also use it for that. But what happens is June 17th of 2015, Merck has to pay $6 million for a misleading marketing campaign of a pink eye drug. So obviously the pink eye, this is just general media, but herein lies the rub. If it is FDA approved for a specific condition, that is what that drug needs to be marketed for. You can talk with the, as Dr. Caldwell mentioned, the medical liaison and talk about its mechanism of action, its pharmacokinetics and dynamics, and how that can be used in a clinical setting. But the drug rep cannot come in and market outside of that FDA approval, because that's when bad things happen. But you can see that it was not covered by federal healthcare systems, which paid millions of dollars to prescribe Azozite for a blepharitis when that was not its FDA approval. So here is that it's a double-edged sword that the use of an off-label medication is absolutely within your purview as a licensed practitioner and provider, but it's the marketing of that drug that's sometimes where that line gets blurred a little bit. And as a provider, you just need to make sure you're understanding who is giving you that information and if there is a motive for that information to be given to you. So that wraps up our anti-infectives. So we're going to move on.
1 second, Doc. You have a question before wrapping up?
Absolutely.
Question rolled into the chat box. Great question. Would the dosing for Zirgan to treat EKC be the same as treating for herpetic keratitis?
Yes. So what I've done is I follow the same protocol to make it easier on myself. And from all the studies I've read, they use the same dosing protocol for both. That's an excellent question. I can even dig further into that and see if they've changed, but the randomized clinical trials I've seen use equivalent dosing for both conditions, but that's an excellent question. Absolutely.
Yeah, I've used it in the office for adenovirus. Yeah, 4 or 5 times a day. You just tell the patient, hopefully they get it in 5, but usually people are used to 4 of getting medications in their eye, and you'll get a significant reduction.
Absolutely. And as I mentioned, it is a far cry better than Viroptic. So if anybody remembers using Viroptic, it stung. It was like 9 times a day. It was cytotoxic. So now you're killing off the herpes, but you're also killing off some of the epithelial cells, and you're starting to decrease the wound healing. The beauty of Zirgan is it is targeting the herpetic DNA. So you are leaving the healthy cells alone, and you're going after just the herpetic DNA. It's much like using a Cyclovir or a Valcyclovir. The reason it has such a safe drug profile is because it's specifically after the herpetic DNA. That's why people can be on suppressive therapy for years, and there are very few drug interactions, is because that acyclovir is so very focused for herpetic DNA only, just like Zirgan. So, but excellent question. Excellent question.
I'm going to give another clinical pearl out there. When you say Zirgan, it always kind of creates a bell to ring in my head. There's 2 medications that I have my local pharmacist keep in stock. So obviously I always prescribe to the pharmacy that the patient wants. And then if they call and say we don't have it in stock, I have my local pharmacy, which is literally like a half mile down the road, keep 2 medications in stock for me at all times. One is 1% atropine and the other one is Zirgan, because a lot of the times they'll be like, oh, I'll be able to get this in the next 24 to 48 hours. But, the patient obviously has a herpetic lesion or an adenovirus or a uveitis. So I'd like for them to keep those 2 in stock. So those Zirgan kind of sparked that.
Absolutely.
Hold on, Chris, before you move on. Would Zirgan reduce symptoms at the same rate as betadine and anti-inflammatory drop for EKC patients?
That's an excellent question. In my clinical experience, the betadine is quicker. The betadine is like a scorched earth. Literally, you're going to throw some betadine on the eye. That's maybe a terrible analogy, but the betadine
I think
is
it's a
going to
great
go.
analogy.
It's going to go all the way across the eye. It's a surgical prep, is what it is. So you are absolutely removing all of that causative organism in one fell swoop. The downside is it is not specific like Zirgan, so it does cause some secondary inflammation. So that's why our protocols would usually also entail a loteprednol or a topical Acular, something that's anti-inflammatory with some artificial tears after the treatment, just for comfort measures. But in that case, betadine, boom, one treatment, they can walk out the door. Zirgan, they're going to be on it for that 3 to 5 days, and it's going to take a little time for that effectiveness to build up.
And Chris, I've done the betadine, and just to echo so everyone's clear, one and done with betadine, but they're leaving, in my case, 100% of the time, I guess 99, like Ivory Soap, 99.9% of the time with a steroid.
Yeah, absolutely.
Right? They're leaving with something, right? So, but if you're using Zirgan, you're going to kill the organism. And in my opinion, you're going to be adding a steroid again, because now you got dead protein laying around on the eye, dead virus, but it's not going to be the day of, it's when you follow them back and see reversal, you'll add the steroid.
Absolutely. Nope. That's a very good point. Very good point. Absolutely.
Okay. So it looks like that's good. All the questions are caught up, and why don't you jump into the anti-inflammatories?
You got it. So what we'll do is we'll talk a little bit about the Pred Forte, Durezol, everybody's favorite topical Nsaids, and then Restasis. And really, I know Restasis and Cequa have not, I wouldn't say fallen out of favor, but when I was in school in 2005, I know I'm dating myself, essentially Restasis was everything. Restasis was going to change the world. Restasis took all the thinking out of managing a chronic dry eye or a post-PK, because post-PKs were really big then before our CX, the corneal cross-linking. But Restasis, I think, has really found a new niche for me, and we're going to talk about that in one moment. So I only put this out there just to kind of set the tone a little bit. So you can see that all of the topical corticosteroids in red are all of the ketone-based, and then I put the ester-based loteprednol in green. And so really, I think as everyone's aware, the ketone-based versus the ester-based, the ketone-based tends to have a little bit better penetration of the cornea. It tends to be have a little bit more side effects. So that IOP increase, those potential long-term posterior capsular opacifications, there are IOP increase. You can have some of these changes that are a little bit more likely by using a ketone-based, because it's not metabolized directly on the surface. Loteprednol, by contrast, is metabolized directly on the surface of the eye. So you tend to not have as many of those side effects. And in fact, when I've looked through the literature, I'm really not aware of anyone having a IOP spike. I'm not really aware of any cataract formation of anyone using a loteprednol in the clinical sense. So if anyone knows those, I would love to see that. But the reason I put that up is because you can see the in vivo versus in vitro potency, and you can see how very different they are. So I think this is just always kind of a consideration that if you're going to choose a steroid, they're not all created equal. And it really depends on two things: what you're trying to treat and what your desired endpoint is, how long it's going to take you to get there. So we'll talk a little bit more about other discriminating factors here in one moment. So prednisolone acetate, Pred Forte, the go-to for so very many of us. It is FDA approved for, and this is also an important one, inflammation of the palpebral and bulbar conjunctiva and the cornea and anterior segment of the globe. The reason I bring that up is because you can see its first FDA label was received in 1975. And I think that's why it's so all-encompassing, because you can see over time how the FDA started tightening up what it would approve for and how broad its approval would be. So when its first FDA label was approved in 1975, it was pretty broad. I mean, you're talking all the conjunctiva, the cornea, and the anterior segment of the globe. that's a pretty broad approval. So you can see what it does is the disruption of the inflammatory cascade. And what I wanted to put in there, because this is going to come up in a moment, it actually downregulates some of the VEGF. So if it downregulates some of the VEGF, maybe there's a role for prednisolone acetate in some of our wet AMD patients, in some of our diabetic patients, because it's not meant to be a standalone, but an adjunctive therapy that if they are undergoing some of these anti-VEGF injections, maybe there's a role for us to kind of move in and say, hey, here's another adjunctive supportive role for these topicals as we're managing them post-injection or post-surgically. And so you can also see that the evidence is also emerging in an in vitro sense that there's a gene expression involvement for inflammation, angiogenesis, and oxidative stress. So really, I think there's going to be an emerging role for these topical corticosteroids in the management of all of these anti-VEGF injections. And I have some literature that we're going to talk about in one moment. But you can see the off-label uses. I think a lot of us have also just adopted using Pred Forte in the management of KCS, dry eye disease, just those kind of ocular surface disease, because we've learned over time from the TFOS and the DUs that there's an inflammatory component. So if you can knock down the inflammatory component in dry eye, you can actually get a lot of symptom resolution, and you can start to re-equilibrate, if you will, or bring back to normal kind of that tear sandwich of the lipid, aqueous, and mucin. So I think by knocking down that inflammatory cascade, there's some real value in the management of your dry eye. But here's the one I want to talk about, is very specifically for your Sjogren's or your KCS patients, that if you go all the way to the bottom, you can see that Keratitis sicca, or your KCS, they had these elevated levels of nerve growth factor, and they were actually decreased with a very low prednisolone on top. So I think there's some role for not only managing that VEGF expression, but also down-regulating some of these inflammatory pathways. And so the trick here is just making sure you're monitoring them closely, because as we mentioned, prednisolone acetate is a ketone-based steroid. So that does have that potential IOP, cataract formation. You need to be very aware of monitoring them at regular intervals to make sure you don't put them in a bad spot. But I think prednisolone acetate has been a workhorse for me clinically, and I think for many of us at home. So Durezol came on the market. I think this one was also very interesting, because this one, as I showed on that first slide, is incredibly potent. Its dosing is typically only BID, but it is incredibly potent. It stays on target much longer, but because it stays on target much longer, this is also where that risk of an IOP spike comes in. And that's where you got to be a little bit more judicious in the use of your Durezol with patients. But I do really like using Durezol, and I'm going to show you a couple examples here in one moment. But you can see that the FDA approval, it's for post-surgical inflammation. So many of us that have say, an endogenous uveitis, or just a stubborn recurrent uveitis, iritis, iridocyclitis that we just can't get rid of, the Durezol has been very nice because its dosing is less, it stays on target, its half-life is a little bit longer, and so you actually find a little bit better resolution of endogenous iridocyclitis and uveitis, especially when it's caused by a systemic inflammatory condition, much like Crohn's or irritable bowel disease. So the one thing that I want to push is, if you take a look at the endogenous uveitis, here is the reason that I've used it so often, is because if you look at the difluprednate treated eyes, more of them were quiet after 3 weeks of treatment and were much less likely to be withdrawn. So its original FDA approval is for post and pre-surgical management, but in fact, you'll find in the literature that a lot of individuals, and I'm sure individuals on this call tonight, use this clinically for some of the uveitis and iritis. So I think that's one of those that, although you know what the FDA approval is, by convention, by just standard of care, I think we found that Durezol has found a place in many of our management arsenals. And so, this one did not come over quite as well. So what I also wanted to talk a little bit here is, so much we talked about the COX-1 versus COX-2. So that was when we had a lot of those oral medications that were having links to heart attacks, heart disease. So these are the topicals, but you can see that the COX-1 and COX-2, if you go to that bottom right, you can see that the COX-1 is not necessarily a pathway that you want to completely inhibit. You'd actually rather focus on a COX-2 inhibition, and that's why you've heard so much about you want a COX-2 selective. So when you look at those ratios, you really want a big number on the bottom and a very small number on the top. So you can kind of just use your best judgment on that one, but you can see how the ratio is so very different, even within the same class of NSAIDs. And if you can find a very selective COX-2 inhibition, that makes a big difference. You're still getting all of the positive effects, but you're not getting quite as many as the adverse effects. Again, being completely honest, this is a topical medication, so GI protection and platelet aggregation, not as concerning for us because that's not going to occur on the surface of the eye. But just as a practitioner, kind of being aware that there are differences in its COX-1, COX-2 ratio and how effective it is in both pathways. And so here we'll put this one up. Non-steroidal, so NSAIDs, those still have, I think, a very strong place in everyone's toolbox. FDA approval, you can see it's pain and inflammation associated with cataract surgery. So that's another reason that very first question in the polling, when it says, do you use any topic, or when you do use any medications off label? In fact, I think you might find that all of us do in some way, shape, or form use a medication off label. And it's only because it has been the standard of care. It's been so widely used for so long that is what we have learned in school. That was what we were taught in residency. That is what we have just adopted as a clinical practice because we know it's safe, we know it's effective, and we know it's available to the patient. So that's why this FDA approval, I think that I want to steer people away, just like what we talked about at the very beginning in this discussion, that off-label medication use doesn't mean it's bad, doesn't mean that it's wrong, just means that you need to fully understand what you're using that medication for. So if we go down, you can see that the off-label uses, allergic conjunctivitis, dry eye, and cystoid macular edema. I think this one I want to put up because it's not just CME, but the diabetic macular edema. So this one came out in 2020. So you can take a quick look at the methods and results. But as you're reading through those, I'll go to the very bottom, that essentially a use of a topical, this is a topical steroid plus an NSAID. So they're really just hammering that arachidonic acid pathway. But what they did was they used a topical steroid and an NSAID in the treatment of DMA to delay intravitreal injections or replace them altogether. And if you go to the very bottom, you can see that they are looking at a proof of concept that I would never advocate, saying to the patient that we're going to get rid of the need for an intravitreal, because that intravitreal, that is the standard of care. But there may be a way that if you have a very hesitant patient, a patient that's reticent to go to ophthalmology to have an injection, there might be an option from a topical standpoint to offer to help mitigate some of those early diabetic macular edema changes, and maybe also as an adjunctive therapy to those that have had an anti-VEGF. But how do we kind of speed that process along, and how do we affect a different pathway than the VEGF pathway to also not only improve acuity and visual function, but also restore that anatomic retinal layers to pre-disease conditions. So here we talked a little bit about topical cyclosporine. So the Restasis, you can see it's FDA approval for keratitis conjunctivitis, so KCS and dry eye. If you go down into the myriad of off-label uses, if you get into Restasis, this is a highly researched drug. There are so many randomized clinical trials on Restasis out there, including Cequa, just at a different dosage. But you can see that because it is an anti-inflammatory and it actually is an immunosuppressant, so because of that, it doesn't have all of those steroid side effects, but it can also help you in the treatment of a long-term inflammation. And so it's that long-term inflammation that I think right in here, we look at a herpetic stromal keratitis. So if you have a herpetic stromal keratitis that you're a little bit concerned to throw a steroid on, because you know how putting that steroid on will affect essentially the healing a little bit, and it can also potentially bring that herpetic condition back if not dosed at the right time in the treatment timeline. You can see how using a cyclosporine might be a viable alternative. And so at the very bottom, essentially using cyclosporine and prednisolone acetate they were nearly equally effective at treating a herpetic stromal keratitis. So Zirgan with a cyclosporine might be an option. I would also posit that using cyclosporine for a really stubborn uveitis that you're trying to get under control, because it's a slightly different pathway in the T and B cell modulation than the arachidonic acid modulations. You could say that I could use a prednisolone acetate plus using a cyclosporine. You're affecting two pathways and getting a synergistic effect. So this might be another adjunctive treatment for your patient population. So question 2, how often do you perform imaging, really any type of objective measurement, after identifying a clinical finding?
So Chris, that was cyclosporin 2%, right?
Correct. Yep.
So that would not be restasis, right? So we don't want people to think that.
No, absolutely. So it's a higher dosage. You're absolutely right. Yep. So the reason that I wanted to put in that topical cyclosporine is I think there's a value in having a commercial formulation and utilizing that as an adjunctive measure to a standard anti-inflammatory.
Right. And that's, I just wanted to make sure that people they were looking at the percentages. I think it's 0.05, 0.005%, 0.05% for restasis. This is versus 2, not thinking that they could just take restasis and use it in a sense off label. This was 2%. And that's what I think the biggest issue with restasis is that it's just, just too weak of a concentration. And that's, it's why I think Sun came out with 0.09% and then changed the vehicle to kind of try and push it through. So, but that's just a higher percentage here. So I launched your poll.
Excellent.
And I did add to the poll because I can do that. And so the second question I added to this poll was, have you ever seen an IOP spike with loteprednol?
Ooh, I might have set myself up for failure on that one because I have not, but we'll see what the we'll see what the
I see it quite often. That's why I threw it out there. So
gotcha.
Just FYI. So
understood.
I just had one the other day. So even with the new Isuvis 0.025%, which is half of the 0.5%. I had a patient come in with a pressure of 24 and they started off at 14. So
interesting. Yeah, I have not seen that with a loteprednol. So I would be interested too that the loteprednol causing the IOP spike, typically the steroid responders are also those higher risk patients for development of primary open angle glaucoma long term. And I wonder if there's a relationship to responding to both a ketone and an ester-based steroid. Are they at even higher risk because they're that much more sensitive to a steroid?
Yeah, that'd be great. That'd be great to kind of dig into. So. All right, we're getting there with your poll. I'm going to end it here soon. And we'll share the results. So we have basically your first question. How often do you review systemic medications and the dosage with the patients? Are you able to see the answers there?
Yes, sir. Checking right now. Yep.
And then I just added at the end there, have you ever seen an IOP spike with loteprednol? And you can make it 19. I can't vote, so 19 of us have seen it. So
gotcha. I must just be very, very lucky because for whatever reason, that's the loteprednol is kind of my go-to on that one. But actually, that's why I really love these presentations because it helps me maybe reframe what I thought I knew about clinical practice because it changes so quickly. And if that's something I'm going to have to start tracking a lot more closely because I just want to make sure that number one, you want to take care of the patient. So I'm going to have to really reevaluate and take a much closer look at that.
And I believe I was trained on the Isuvis slide deck, and I believe that, they had, how many, the N of 200 or an N of 500, and maybe one or two did spike, and even in their group. So
okay,
I would say it can happen. Just be careful. So. All right, let's see here. We got one that rolled in here. It says treatment of treatment of a primary open angle glaucoma patient and CME can also cause an increase in IOP as a side effect. And is it always contraindicated to a prostaglandin analog with CME?
So
the first question is, primary open-angle glaucoma and CME can Acular also cause an increase in IOP as a side effect?
Not in my experience, and I think it has most to do with the where it affects the arachidonic prostaglandin development pathway. So NSAIDs, I am not familiar with an IOP increase with NSAIDs. Certainly corneal melt, extremely rare, but the biggest, I think, barrier to more people using NSAIDs is trying to find that right pH balance, right? So they need to keep that concentration of the medication proper to maintain an effectiveness of the drug. But that pH doesn't match your tear film pH. It stings like a bugger when it goes in, and you'll have some compliance issues. So short answer to the question, I'm not familiar with an IOP spike in NSAID use, no.
And I agree. I don't know if there's any out there that have been reported either, or even in some of the studies, the slide decks too on the NSAIDs. And the second question is it always contraindicated prostaglandin analog with CME?
This is one of those board exam questions when you say always or never.
Right, exactly.
So I would honestly say it probably comes down to your risk benefit ratio, meaning if you can't find a better class to manage that POAG and they are not a SLT or an LPI, they're not a surgical candidate, and there is no class to keep that pressure down, I don't think it's necessarily contraindicated, but it needs to be monitored very, very closely because they're already susceptible, especially if they're pseudophakic. They're already susceptible to some inflammation at the retinal level. So I think you just have to watch them more closely, and that's where that retinal imaging might play a positive role, that you could identify some very early subclinical changes. So no is my answer, but with an asterisk, right? You just got to monitor it very closely.
Yeah, I mean, macular edema, that's kind of a loose, big, broad paintbrush to go by, right? So, I mean, that could include diabetic macular edema. That could include, edema from trauma. It could be edema from cataract, surgery, so on and so forth, trauma. If you have an intact capsule, if you have an eye that's not traumatized, and just like Chris said, the risk versus benefits that are out there, is it always contraindicated? I'm going to say no. Are there other good products out there that you can use? Absolutely. But there's times where, people just need latanoprost because that's the only thing they can afford. And you might have to use it. So.
Absolutely. Nope. Very good. Excellent questions. Excellent questions. Thank you. So let me push this one forward. And all right, so good timing on all of the glaucoma questions. So what I'll talk about a little bit is acetylcysteine or acetylcysteine. We're going to talk about N-acetylcysteine specifically, and then we'll talk about some of the anti-glaucoma medications. And it's the Rho kinase inhibitors where there's not quite as much RCT literature out there. A lot of it is still in animal models and still a lot in the in vitro realm, but there's some promise with those Rho kinase out there. And so we'll talk a little bit about those. So Mucomist, so this is one where in the US, this is not readily commercially available. Being at a university, being in the US Air Force, we can have the pharmacist compound this for us. So that's why it's still in my arsenal. But I do think that having a mucolytic agent is quite a value. And so you can see that it's FDA approval is obviously for a systemic condition, but a lot of us, I think we're trained and grew up on filamentary keratitis, right? So that's what you would use the Mucomist for. But if you'll see that vernal and giant papillary conjunctivitis, that also fell within the wheelhouse of what you would use a Mucomist in a commercial preparation. But what I would propose is this one actually kind of came out, and we use it quite a bit within the Air Force when we do humanitarian missions and work with our counterparts in, say, the Central and South American countries. It's actually used post-pterygia removal to help the decrease the recurrence. Because certainly when you do a pterygia removal, there is some time that passes before that pterygia will, regrow and progress along that same path that's laid down. But there's some very interesting data out there that actually using N-acetylcysteine after the surgery kind of slows down all of those fibrotic changes that led to the development of the pterygia in the first place. So I think that this is a very interesting option to use for those patients that have those stubborn pterygia. They had them removed, and man, here they come back again. just an option to say slow down that pterygia progression and maybe prevent a secondary treatment in the near term. So I wanted to put this one out there because it's just a very interesting option or adjunctive therapy. It's not going to replace necessarily anything that you do in your clinical treatment realm, but I think it's a nice adjunctive option. And sometimes too, it's better than an anti-inflammatory or long-term, say, corticosteroid therapy. So using this N-acetylcysteine is a very nice option to slow down pterygia return. So I want to put that out there. So now we'll get into some of the glaucoma medications. So aproclonidine, clearly, because cocaine is a little tougher to find these days in a compounding pharmacy, its primary role, I think, especially at the university when we are working with students and residents, is for the differential diagnosis of foreigners. And so we won't walk through the parasympathetic and sympathetic chain and do all of that. But what I will say is look at its FDA approval. So it's the control or prevention of post-surgical IOP following laser trabeculoplasty, laser iridotomies, and a posterior capsulotomy. So you can see that although it's a glaucoma medication, its primary FDA approval is for post-surgical treatment. So this is not really a first-line glaucoma medication, but I think this is one of the interesting off-label uses. It really works pretty well to act on the Mueller's muscles and those alpha adrenergic receptors, and you can actually get a little bit of a lid lift by using that. So you can walk through kind of the methods and the results, but getting all the way to the bottom, using a topical aproclonidine clinically, you can have as a off-label alternative for mild upper eyelid ptosis and eyelid asymmetry. So this is one that we have used clinically. It's usually just a drop, maybe 10, 15 minutes beforehand. I wouldn't have them use more than maybe 2 in a day, but it will have some hours long lasting effects. But this is for the individuals that have wedding photos or have a picture day or something like that, and they have a non-traumatic or a non-mechanical ptosis where there's just a little eyelid asymmetry. There's quite a nice reaction in a large segment of the population. So this is something that we will use mostly from a cosmetic standpoint, but it's nice to have in that arsenal because if there is just a slight eyelid asymmetry, it's nice to offer your patients a remediation, albeit temporary, just something that maybe sets you apart from your peers. And so we'll stay in the same alpha adrenergic agonist, so brimonidine. So this one, unlike its kind of kissing cousin, if you will, aproclonidine, alpha-GAN-P is for the reduction of elevated IOP in POAG. And this one, we actually use quite a bit in the refractive surgery realm. So not as much now in the newer all laser procedures, if you will, where there's a better blending of the zones. But when I first came in 2005, 2006, when I did my residency in 2008, essentially we would have a lot of these individuals that were young, healthy, and when their pupil was a little bit larger than the treatment zone, holy cow, they would get all kinds of glare and halo at night. There'd be all kinds of post-surgical visual symptoms. And so what we found is that using a topical brimonidine actually reduced quite a bit of that. And so this is the one where it came out of 2008. There was actually a study, it's not this study, but came out of Brooke Army Medical Center, that in individuals with night vision difficulties after surgery, where that pupil was just larger than the treatment zone, you would actually get some improved contrast sensitivity and decreased night vision difficulty. Now, caveat on this, if you've ever used this clinically, it's very, very important to talk to your patients about using this before they get behind the wheel, that they need to know how reactive that pupil is going to be and that it still allows some good night vision driving. This isn't necessarily like a miotic. This isn't going to shrink that pupil down and keep it down. It is still reactive to light, but it is going to make it a little bit smaller. And in low light scotopic conditions, it's not going to dilate fully. So there is kind of a trade-off on that. But I will say that even if you have that patient who has all kinds of night vision issues, even if they're not a refractive surgery or a post-refractive surgery patient, this has been a nice adjunct within the university that we will give this to young females, young males that have a lot of night vision issues that we just can't get a handle on. So just something to keep in your wheelhouse, just something to keep in your back pocket that A topical bromonidine does a very nice kind of treatment to reduce glare and night vision difficulties. So Dorzolomide, this is another one that as you start to peel back the layers of the onion and you get in deeper into the research literature, Dorzolomide, I think, is vastly underutilized in a clinical aspect, especially from a primary care aspect. So essentially, it's a carbonic anhydrase inhibitor. So if you think of other carbonic anhydrase inhibitors, it's pulling fluid out of the tissue. So it's FDA approval. It's a treatment of high IOP due to open angle glaucoma or ocular hypertension. But its pathway essentially is decreasing the sodium-driven fluid transport in a tissue. So if you think of individuals that have HACE or HAPE, high altitude cerebral edema or pulmonary edema, it's pulling the fluid out of the tissues. And this is a topical medication in the same class. So what I would say with that is if you have individuals that have a chronic CSC or a chronic macular edema, and just like Greg mentioned, there is a wide spectrum of what that macular edema is. But this essentially is a nice adjunctive therapy, not a replacement therapy, but a nice adjunctive therapy to help pull some of that fluid out of the macula, to pull some of that fluid out of the retina, potentially decreasing its thickness and restoring some of that visual function. So you can see this one came out in 2020. They were looking at it from a central serous chorioretinopathy. And if you go all the way to the bottom, you can actually see that the topical CAI resulted in more rapid reduction of central macular thickness compared to observation. It's not a magic bullet. It's not going to resolve fully in everybody, but I think it can speed some of that resolution. It can decrease some of that chronic stress and stretching on the receptors and some of those intraneuronal processes. I think there's some value in considering this when looking at a long-term central serous or a macular edema in general. So I didn't put all of them up here for sake of time, but if you get into diabetic maculopathies, if you get into some of the other even cystoid macular edema, because of its pathway, because it's a carbonic anhydrase inhibitor, it's going to slow that fluid transport and actually decrease the thickness in addition to whatever else you're doing to manage it. So I think this is a really nice adjunct, and we're going to talk about it more here in a moment. So we're moving on to beta blockers. So a tried and true Timolol 0.5%. The reason that we'll look at the Timolol because it is both receptors. So we're looking at beta 2 and little beta 1, but mostly beta 2 blockade. And you can see its FDA approval is for the treatment of elevated IOP with ocular hypertension and open angle glaucoma. So you see a theme developing. All of these glaucoma medications, surprise, are for glaucoma. But understanding their pharmacodynamics, understanding what a actual beta blocker does and what other organs or end organs that they work on can really play a big role. And so here is one that we have used quite successfully. It's actually a crossover for acute migraine. And so if you think of propranolol orals, Inderal, that is actually used widely right now in the management of migraines. And so this came out of JAMA in 2018. There's a follow-up study from the University of Missouri in Kansas City. And what they found was that using a topical Timolol, 1 drop in both eyes, wait 15 minutes, 1 drop in both eyes, actually worked almost 70% of the time to reduce migraine symptoms and was superior to placebo. So certainly the Timolol, need to be aware that there are contraindications. So it is a beta blocker. So anything with respiratory cardiac issues, proceed with caution. But I think this is a really nice adjunct for those migraine sufferers that you have all the time in clinic, and they'll let you know that they're on a triptan, they're on an abortive therapy, they're on a chronic management therapy, and you're looking for something to just kind of take the edge off those acute onset. I think a topical Timolol is a very nice option. And so if you go all the way to the bottom, you can see that this JAMA publication in 18, it found that Timolol 0.5% is an effective abortive treatment for some patients with migraines. Again, not a magic bullet. Virtually none of these off-label medications that I'm discussing today are going to solve everything for everyone, but this is where the clinician and you need to come to play to understand what is the best fit for my patient, my understanding of the class of medications and how it fits into the overall patient management schema. That is for you to make that individual decision. But I will say that topical timolol, I've gotten more hugs from patients using this protocol than virtually any other protocol, because this is that game changer. They have an abortive one, they put it on, boom, it's straight into the eye, straight into the CNS absorption, and it bypasses that cytochrome P450. So there's not that wait for an oral to kick in. It gets on site immediately, and you can get relief very, very quickly after installation. This one I just put in there because as I was searching, this is something that we don't manage, and I have not ever managed myself, but I thought it was just interesting. You can see the photo montage on the bottom. This is actually a topical timolol used for a pediatric hemangioma. And you can see what it's doing is it's acting on the vessel walls, and it's causing resolution and a speeded resolution. Again, it's not going to work for an advanced or a very deep hemangioma, but those superficial hemangiomas that many of them tend to resolve with time, this can help from a cosmetic appearance and kind of speed that along. And because it is a topical administration, there's very few side effects, that it's not even going into the eye itself. It's a topical cutaneous administration. And if you'd like, I put the journal up there in the journal article. If you'd like to read more into the mechanism of action, how it's applied clinically in dermatology, this is just a nice adjunct for those pediatric optometrists out there that may have a patient or may have a patient's family that would be interested in exploring this option. This one I want to put up there because this is a combination of the beta-2 and then the carbonic anhydrase. So this is COSOP, which all of us are very familiar with, but you can see some of the off-label uses in the literature. The reduction of a persistent exudation in neovascular AMD and diabetic maculopathy and full treatment macular holes. And I think that's why this is so very interesting, because what it's doing is it's doing a combo at the same time, because it's a combination drug. It's decreasing the IOP, so it's allowing that tissue to kind of come back to its normal setting, and it's also pulling the fluid out at the same time. So if you want to take a look at this, is using essentially topical COSOP versus a placebo in eyes with neovascular AMD that have persistent exudation following intravitreal. So reading through the methods, results, the conclusions, I think, are what are important for us. That topical COSOP with NV AMD will result in anatomic improvements, but not necessarily VA improvements. So this is that one where you have to tread lightly, because certainly the patient's number one concern, I've had a lot of people, doc, thanks for telling me all about how thick my macula is, but what does that mean to me? I can't see clearly. Everything's a blur. Is that ever going to come back? The protocol described here will reduce that central macular thickness, but not necessarily improve their visual acuity. But I still think there is some value in saying that, hey, I've got an anti-VEGF. We want to speed resolution, return the anatomy to its original form. Here's an option in a primary care setting that you can use in conjunction, in addition to anti-VEGF, and try to get that retinal anatomy, get that macular anatomy back to the way it should be. And I think this is a really nice option. The study itself did not show a lot of visual acuity improvements, but I think that is to follow. And I think if you just reduce that central macular thickness, there is still some functional, qualitative visual improvements that you can provide. So here's the one that I talked a little bit about, Rho kinase inhibitors. These are relatively new. I will say that I have some limited experience clinically, essentially within Air Force optometry. A lot of these aren't even on our formulary, so they're not even available for us unless you work in a specialty glaucoma clinic. You can see the FDA approval, reduction of elevated IOP. So a lot of consistency in what the FDA approval is for. But you can also see, going to the very bottom, essentially what it's doing is it's working through the trabecular meshwork, but its off-label uses that are published in the literature are diabetic macular edema management and corneal endothelial function. So I thought that was the most intriguing one to me, because I think a vast majority of us are going to see significant guttata. A lot of us are going to see a Fuchs that we're right on that cusp of requiring some type of DSEC or DLEC, or even some type of penetrating keratoplasty. That corneal endothelial layer is starting to reach a dysfunctional point where there is very little value, and even the hypertonics surgery is the next step. But some of this Rho kinase inhibitors show some value for Fuchs corneal dystrophy. So you can see, again, going through the methods, going through the results, This is one where it does not have a large RCT or randomized controlled trial. These that you'll find for the rho kinase inhibitors, because of its newness, if you will, relatively speaking, are not have a lot more case studies and case series type of presentation in the literature. But if you go down to the conclusions, using a ROCK inhibitor as an alternative to graft surgery in certain forms of endothelial disease, I think, in my humble opinion, this is really a no-brainer. If you can somehow stave off the need for penetrating keratoplasty or a graft, if you can somehow return some function to that endothelial layer with a topical medication as opposed to a surgical correction that comes with its own inherent risks, I think this is something that does need to be trialed. Now, certainly, I will say that I don't have a lot of experience with this one, but I did want to bring this in because from a primary care standpoint, this is very, very promising. This would be very exciting to me in a corneal practice to see if there is a topical option or topical alternative before referring someone for a full penetrating keratoplasty or graft.
Hey, Chris, I'll kind of want to feed off of some of this of what you're saying here. And my N of patients with successful use of, say, maybe moderate to advanced Fuchs disease is 2 successful patients. I might have tried it in, say, 8. So it does help using Notarsidil, that Notarsidil product, the Repressa. I've had some people that just had some really bad, I mean, they were bullous keratopathy and they were just refusing surgery and so on and so forth. But a mild Fuchs, I've had patients where it has responded nicely. However, what I want to feed off of is when you're using your Dorzolomide for your central serous, or you can even use it for PEDs. Brad Sutton did a nice article kind of showing that those kind of both have the same pathophysiology. That be careful with Dorzolomide because you think you're pulling edema out in the macula or central serous or PEDs, but check that cornea because the endothelial cells need carbonic anhydrase inhibitors and you can create swelling to the cornea. So you think you're fixing swelling in one part, but you can create it in the other part of the cornea. So watch that out there sometimes, or, it's kind of a board question, which one of these glaucoma medications should not be used in a Fuchs patient, and is carbonic anhydrase inhibitors. My last comment would be, since, Joe and I do a lot of lecturing in neuro, and you're correct that, small pupil, small ptosis could be a big problem. That could be a Horner's, it could be, a Pancoast tumor. It could be a carotid dissection. Typically, it's more of a carotid dissection than anything. But I have our colleagues that always hear, you could use iopidine to see if you can get that reversal. We don't really keep iopidine in our office unless we're like in an ODMD practice where they might use it for YAG caps or have it in the office. But we do get Alphagan. And if I can use Alphagan, and they're 2 different receptors. So you cannot use Alphagan out there. I want our colleagues to realize it needs to be iopidine based on that alpha-1 weak receptor part that does respond whenever you use iopidine for Horner's, not Alphagan. I've seen colleagues kind of be like, oh, it must not be a Horner's because I used Alphagan. It's the same thing, iopidine and Alphagan, and it's not. So
absolutely true. Absolutely correct. Absolutely.
All right. There's a bunch of questions that rolled in here.
Okay. What do we got?
So let's see here. All right. Let me scroll up here because they just keep rolling in. All right. Treatment. There it is. All right. Is neuroprotection for visual field defect for drusen still off-label use with Alphagan?
This is one where I get this question a lot. The neuroprotection that I've seen from Alphagan P is great in theory, but I have not seen it in practice. I don't know if the evidence is there to use Alphagan P as a neuroprotection because I just haven't seen it well-defined in clinic. And Greg, I might defer to you on this one too. I don't see neuroprotection from Alphagan P, but maybe you've seen something different in your practice.
Yeah, this gets discussed about every year, at least every other year at the OGS meeting, the Optometric Glaucoma Society meeting, which is a group of ODs and MDs that don't care if you're OD or MD and get together and we really talked this all out. And, you know, the one thought is we've been talking neuroprotection for 21 years. And just like you, Chris, no one has seen it. We've heard it. It was good theory. Now, regarding the visual field defect from drusen, what they've identified is drusen are not static in the optic nerve, they're kinetic. So they move through the optic nerve, and the optic nerve changes its shape. That's what kills the ganglion cell. That's what kills, you know, you have like a rock in your shoe, you got a rock in your optic nerve. That's what's killing the nerve fiber layer. So adding the alpha-GAN has found not to be protective in the kind of the, even if they have a visual field defect, it could get to severe visual field defect, but that's just because those rocks, those drusen, are moving through the optic nerve. So it's, you know, I can always try, you know, it's better than doing nothing, I guess, if you want to do something, but nothing has ever been shown that that does help, if that makes sense.
Absolutely. And I'll piggyback on that, because we're going to talk about an oral medication that has been shown to have some advantage in some of the high risk features of AMD, specifically drusen formation early on. And so I haven't seen literature that necessarily refers to the optic nerve head drusen, but certainly from macular drusen, we're going to talk about that here in just a few slides.
Does Lumify have, you got about a bunch here, so hold on a second. Does Lumify have any effect on pupil size in young patients suffering from nighttime glare? Does it have enough concentration to have an effect?
In my experience, not really. I mean, some might, but because its concentration is so very low, it's really isolated to the vessels on the superficial conjunctiva. So again, Greg might have different clinical experiences on this one, but the Lumify concentration, because it's so low, typically spares the pupil, but acts on the surface and the more superficial conjunctival vessels.
Yeah, and I would agree. And I would say that even if it did shrink the pupil, it's not going to last long because it's just going to wear off. The efficacy is going to be weak on that. Any off-label use of pseudotumor with topical Dorzolomide?
Ooh, that's an interesting question. If I'm just thinking through the pharmacodynamics on that one, I don't think so, because the pseudotumor is going to be at such a depth and such a severity that you would need oral or IV administration to really get the level of concentration to that target organ. So I haven't seen any literature on that, but I would posit no, just because the topical is not going to penetrate high enough at a high enough concentration to truly affect that pseudotumor.
And yeah, I would agree on that. I mean, maybe adjunctively, but maybe not, you know, certainly not solo on that.
Yeah.
Is Timolol effective for patients with ocular migraine symptoms?
Yes and no. So that's a great question. I did not bring that one up. I have had people report anecdotally, and as I've hammered on anecdotes, I've had people report anecdotally that they don't get as many scintillations. They don't have quite as many of the ophthalmic features to their migraines, but it's really tough. It's really tough for me to know, because I haven't seen a literature that specifically states that it's better for ophthalmic migraines versus a true migraine, cephalic migraine. I would say yes, because it follows the same pathway with that vasospastic pathway. So in my humble opinion, again, I would say yes, there has been some. I have had some patients report that that's improved their ophthalmic migraine, but I haven't seen any literature published to that effect.
Can there be any medical legal implications when an OD prescribes Timolol for a migraine?
Not necessarily, as long as you are, again, making sure that Timolol, it's a beta blocker, right? It's a non-selective beta blocker. So it would be much like, as long as it's peer reviewed, so there's a reason for it, and it's in the best medical judgment of that patient. It's going to depend on your state licensure. So certainly look closely at your state licensure. I'm in Texas, so I will say we've got a real tight state legislature. The AMA is very strong in Texas. So I think as long as you are meeting those criteria that we talked about at the very beginning, that there is a medical necessity for it and that there's peer-reviewed literature to support it, I think if you are following that patient closely and you are clear that there is no respiratory contraindication, there is no cardiac contraindication, I think you would be safe in that regard.
Yeah, I think there's two ways I'd answer that. The first one would be, if it has an ocular, patients with migraines, they get a lid droop, they get photosensitive, they get blurred vision. If they have an ocular issue, then I think it's wide open, right? You're treating the eye problem. It just happens to be that you're treating the migraine at the same time. If a patient came in and had no ocular symptoms, but hey, I have migraine suffer, you say, hey, I've got this Timolol, it might be worth talking to the PCP, getting the PCP to prescribe it, or getting the okay from the PCP for you to prescribe it, that you got a consultation. So
Absolutely, that's fair. Absolutely.
Any value to use of Cosopt in Coats disease?
There is some literature out there, and actually, if this individual wants to kind of follow up with me afterwards, there is some literature out there. It's much like in Ushers and Coats. It can work. It's adjunctive, but it's not going to be your primary role. So it's going to help a little bit, but a little bit on top of the primary standard of care. So if you'd like, there is some published literature out there specifically on Coats disease, and the answer is yes, a little bit. So.
And I guess I was slacking my duties. I could have had the polling question up and running while we were talking there, but we'll let the polling question run here quickly and then let you continue to move on, because you got a lot of great information here. So the question is, how often do you perform imaging topography photos, OCT, after identifying a clinical finding? Always. Only when visual performance, acuity, Amsler grid, visual field is affected. Rarely, if ever. It depends.
So clearly, it depends is you're out on this one. If you're not sure, it depends.
All right, so I'm just that was my fault. We've got a pretty good amount of people, and they're rolling in there pretty fast. I'll let them answer. I'll end it here at a minute. All right, we're going to end the poll there, people. And then here you go, Chris.
Perfect. Yep, I think that's exactly what I would expect. I would say that clinical imaging really is not only a practice growth opportunity, but I think it also can help validate the off-label medication use. If you're able to clearly delineate what the baseline image looked like, and then a subsequent, say, 4-week, 12-week, 16-week, what did it look like after initiation of the therapy? I think it's a really nice way to not only prove to the patient, hey, continue this. It's like a positive reinforcement cycle, but also for yourself that you now have more confidence that this off-label medication is absolutely indicated, as long as I'm treading, I'm walking that line to there is an ophthalmic rationale for it. There is peer-reviewed literature for it, and I've reviewed potential contraindications. I think ophthalmic imaging is a nice option to give to the patient. So. All right, so I know that we're getting to that witching hour, so it's 04:35 my time, so I want to make sure I'm not going too slow.
Yeah, because of the House polling questions, Chris, go to about 48 or 50-ish.
You got it. All right,
we'll land it. So.
Yes, sir. So I'll try to pick this one up. So what we talked about up to this point was the topical medications. So now with the oral medications, this one is really going to determine what your comfort level is with your local PCP or your general practice. I think this is also an opportunity to open that door for conversation and create that synergy between primary care and primary care optometry, because I think there are so many valuable kind of co-options in here. It's a different lecture, but some of the emerging technology, it is for imaging, but it's being marketed for primary care physicians, not ophthalmology, but primary care, because there is an AI component to it. It's outside the scope of this conversation, but I think it's going to nudge optometry that we have to have a strong working relationship with our PCP or our GP fellows. So we'll get into the oral medications. So doxycycline, I think everybody is probably very familiar with doxycycline. This has been a kind of standard of care, a protocol for dry eye and especially recurrent corneal erosion for many years. You can see that it's an FDA antibiotic, and you can see all the prophylaxis. So I'm active military, deployed multiple times. Doxy is a tried and true. So there's not a military member out there that hasn't been on Doxy for some length of time. Well, you can see that again, it's inhibiting the bacterial protein synthesis, just like some of the other classes we talked about. But the off-label medications, dry eye, recurrent corneal erosion, and meibomian gland dysfunction, I think have been really well elucidated. But I wanted to put this one up. And they were looking at using topical azithromycin in addition to an oral doxycycline. So if you go all the way to the bottom, so this one is also including carotenoids, which is a separate lecture, but one of my favorite topics. So when you're using carotenoids, so that would be lutein, zeaxanthin, and azithromycin and doxy, tear film stability is restored and patients will typically resolve. So sometimes you'll get those stubborn dry eye patients where you're really kind of stumbling through each kind of progressive step and how do we get them where they need to be. This is maybe one of the earlier treatments that you can initiate right away. An oral lutein and zeaxanthin supplementation strategy, along with a oral doxycycline with their PCP, and then a topical azithromycin. Even with the azithromycin out of the mix, I think with the topical doxycycline following one of the dry eye strategies, I think there's a lot of value in making sure that we recognize the synergistic effect of off-label meds and understanding the class of medication and their mechanisms of action. And I think this is a very nice study that kind of puts all of those together, because all three of those affect slightly different pathways. So they synergistically are having a positive end state effect for dry eye symptoms. So here's what I mentioned. That was an excellent, almost precog question on the optic nerve head drusen. So oral atorvastatin or Lipitor. You can see its FDA approvals are discussing the high density lipoproteins and low density lipoproteins. But if you go down to the off-label medication, decreased AMD risk factors and reduced progression to diabetic retinopathy. And so I think that this is the one where a vast majority of people are on atorvastatin. It's not been the wonder drug that for a while there was discussion of putting into the water system. Obviously I say that in jest, but there was a time where everybody was on Lipitor and you wouldn't think twice about it. I think there's some emerging literature that it's not a one size fits all. So there's a little bit more judicious prescribing, but this is a class of medications that having a strong relationship with your PCP can be worth its weight in gold. And the reason I say this is you can see that using a meta-analysis and a systematic review. And the reason I like this is because we'll talk about it at the very end, and I'll try to speed up a moment so I don't miss anything. Meta-analyses and systematic reviews take all of the RCTs, take all the case analysis studies, put together like studies, increase the N value to very high levels, and find significance where it would otherwise be invisible, and show that there's not significance where it showed up in a very small N. But when they did a large meta-analysis, the lipid-lowering agents show a protective effect in diabetic retinopathy and may be associated with reduced risk of diabetic macular edema. So I think this is one of those, you're going to have an individual who has diabetes. It's very likely they're also on atorvastatin, but if they are not, this is that conversation starter with that PCM. So prednisone, this one I'll go quickly because I think most people are familiar with, medral dose packs and prednisone. So prednisone, I think, is one of those fantastic options that if it tried to get FDA approval now, it would have a heck of a burden to get over, because there are some side effects to using prednisone long-term that have to be monitored closely. But I think what I wanted to share was prednisone, especially oral prednisone. When I was in school, even in residency, and I'm guessing like most of you, we were told if it is an optic neuritis, you do not in any case even consider using oral prednisone, because it's not going to be effective. And in fact, recurrent optic neuritis could be worsened with prednisone. But hold the phone. They actually brought out a big randomized clinical trial, and what they were looking for was bioequivalent oral prednisone. And the reason I say this is because that cytochrome P450 we talked about, that oral administration versus an IV administration, the bioequivalency by the time it passes through those metabolic pathways is vastly different. So what they found was if you get an oral prednisone, so you can see the dosage, it's a very high dosage. So this is not appropriate for everybody, but at 1,250 milligrams, you can actually get a bioequivalency of oral and IV. And if you get to that conclusion, this is one of 3 articles that came out over the last 2 to 3 years that bioequivalent oral corticosteroids may be an alternative to IV corticosteroids to treat acute optic neuritis. I put this out there because this is for all of those practitioners that may not have an easy access to neuro-ophthalmology or ophthalmology. You may not have easy access to refer a patient for IV corticosteroid therapy. So here is an option out there that is proven in the literature that you can give them some relief, that those oral prednisone at bioequivalent levels can have a safe and effective treatment of optic neuritis. I put this out because it was a bit of a game changer, because this is never what we were taught in school, but it's the bioequivalency is a critical piece. Oral metformin, so I want to speed up a little bit so we're not missing anything, but you can see that metformin, so it's a anti-hyperglycemic, so it's used in the treatment of diabetes, pre-diabetes. But what you can do is, if you go all the way down, it's actually being shown that metformin has some value in AMD mitigation, and especially Stargardt disease. So there's a clinical trial out there right now. This slide deck is for everyone to share and look at, but there's a completion date, obviously a little bit in the future, but it's being used as a potential mitigation strategy for Stargardt disease right now. We'll talk a little bit about use of metformin. So this is for individuals with newly diagnosed AMD. So as our population ages, we're going to see more and more newly diagnosed AMD, and the use of metformin, going all the way to the bottom, metformin use was associated with the reduced odds of developing AMD. It does not appear to be protective in patients with diabetes and coexisting diabetic retinopathy, but it might be a preventative strategy for AMD. So this might be one of those, again, inroads to your PCM and your local physicians to say, hey, this is an individual, they have an AMD risk, here's some existing literature. Maybe there's some value in getting them started on a relatively low dose of metformin, which is widely utilized and widely accepted to maybe slow down newly diagnosed or maybe even mitigate some of the new AMD cases. So here's the clinical outcomes, because this one I want to bring up for metformin. So if anybody follows essentially the anti-aging movement and some of these treatments to kind of reduce the aging or the impacts of aging, they're working very hard to classify aging as a disease process, but that's where the rub comes, because is aging truly a disease process, or is it in a natural progression? And so these are just the clinical trials out there using metformin on pre-diabetes to actually treat atherosclerotic changes. So there's a clinical trial out there for using metformin for a hypertensive and atherosclerotic changes, and there's a metformin in longevity. So they're also recruiting individuals for using a metformin to slow down some of those cellular changes that we see associated with aging. So I think there's metformin, it's one of those tried and true drugs that we're only starting to scratch the surface and what it can be utilized for off-label. So oral lisinopril, FDA agent, so anti-hyperglycemic. So we talked a little bit about that. But if you go all the way to the bottom, you can decrease the progression of diabetic retinopathy and migraine prophylaxis, which does sound a little counterintuitive because typically migraines are not necessarily related to hypertension, but there's some value on that vasospastic activity that lisinopril can provide. So I want to put up the lisinopril with people with type 1 diabetes. So again, in the interest of time, we won't spend a lot of time on the methods or findings, but lisinopril may decrease retinopathy in a non-hypertensive patient who have type 1 diabetes. So this is, again, an antihypertensive med that you use in a lot of diabetics because you're trying to have some of that nephropathy protection, trying to protect the kidneys by keeping that blood pressure low and acting on those loops of Henle. So by using lisinopril, you may have some positive effects on mitigating diabetic retinopathy in your type 1 diabetics. Selenium. So now we're going to talk a little bit about the supplements. So this one I want to put up there because the supplement is not regulated by the FDA, but selenium had a huge trial that came out in the GRASS trial in 2014. And it's all about the proptosis reduction in thyroid eye disease. And so we're all very aware of Graves' disease and hyperthyroidism, but thyroid eye disease, although related, is a separate disease entity and almost needs to be treated as such. And so I put this up there because the GRASS trial, this is one of the first publications that came out, but 2014, they actually found that selenium supplementation can enhance the effect of anti-thyroid medications. My closing slides have the dosages, the durations. So if I haven't been completely clear on dosage, duration, and route of administration, the last few slides, I promise, have all of that encapsulated. but you can see that selenium will enhance the effectiveness of existing antithyroid drugs with Graves' disease. So I think this is a really nice option for those that start to show some exophthalmos or proptotic changes. Throwing some selenium on board as a supplement can actually enhance the effectiveness of the drug that they're already taking. And so this one I put up there because I was unfamiliar. AMD is one of my favorite topics. I talk on AMD at many different venues. This is one I was not as familiar with. It was vitamin E and selenium. Still waiting for any of the results. So the last update was in 19. I haven't seen anything on this, but I wanted, in the interest of completion, the sake of completeness, put this one in for a selenium supplementation related to AMD. So L-lysine, we had talked a lot about herpetic eye disease. L-lysine is a really nice adjunctive therapy. So as well, it's going to disrupt it's going to disrupt some of the enzyme changes. So lysine is going to help kind of put those right. So using about 3,000 milligrams, we'll talk about the dosages and duration in a moment, but using lysine in addition to your oral antivirals or your topical antivirals, L-lysine helps shorten severity and lessen symptoms. And there was a study that came out here in 2020, Journal of Nutrition, so no observed side effects. And so they were all at the 6,000 milligrams a day. Most of the other meta-analyses will show 3,000 milligrams a day, but L-lysine, very inexpensive over-the-counter supplement, can help be an adjunctive therapy to your herpetic sufferers. So even cold sores and the mucosal layers, if you have an individual who has a lot of issues with recurrence of herpes, this is a nice adjunctive therapy. Just because no talk of mine is complete unless we pull some AMD in, but I thought this is really interesting that the AREDS2 formula was actually used off-label, if you will, although there isn't a label because it's a supplement, but they were using AREDS2 in idiopathic macular telangiectasia. So this one came out very, very recently, but if you have an individual who has a non-proliferative, so a progressive but non-proliferative, so you're not seeing a lot of leakage, you're not seeing a lot of macular edema, but if you have an IMT and you start to see changes, using an AREDS2 formulation can actually slow down and prevent some of those long-term changes in idiopathic macular telangiectasia. So just a really nice adjunct. It's a macular condition. It's not AMD. It has a completely different pathophysiology behind it, but using the AREDS formulation does provide benefit. So chromium, this is going to be my last one here. So this one is for anti-VEGF. So this one is a supplement that's not meant to be a replacement, but they found that when you were using intravitreal anti-VEGF, they would put chromium on board. And if that chromium, so they did a comparison, they used Optivision that had chromium and a control that had 0 chromium. And they found that the supplement with chromium, in fact, improved a lot of those findings. So you had significantly less intravitreal injections when you were using a chromium supplement. So not the end all be all, but if you have that individual who is very reticent, as we mentioned before, to have that ophthalmology visit, to have that intravitreal injection, here's a nice option to potentially reduce the number of needle sticks in the eye that they're going to have. Oh, I said this is the last one I want to put on there. This one I hesitated to put on there because I really struggled to find a peer-reviewed literature on this one. In theory, there's some value on this one, but it started showing up on the ophthalmology news, the Helio news, optometry news, and it's the idea that stimulation of the parasympathetic pathway can actually enhance some of the normal lacrimal gland function and just have your eye produce more tears naturally. I love the idea. I think there might be some value there, but the tough thing I'm having is when I read through the supplement facts, I don't know exactly where the active ingredient is because thiamine, vitamin B6, selenium, the first two, thiamine and B6 are both B vitamins, and selenium we talked about, but it's that proprietary blend. And so I don't have a great idea, a great feeling on where the actual pharmacodynamics is on this, but something just to make you clinicians aware of that this Parasim Plus Eyes is being marketed. It's out there right now. And for your dry eye sufferers who want to take an oral supplement, this might be something just to arm yourself with so you have some idea. you can go to the actual site, and this is an individual that had been diagnosed with a autonomic dysfunction, an individual that had some parasympathetic underaction, and this is self-reported data. So I didn't see anywhere where this is published or peer-reviewed, but it seemed to show some improvements. So I guess take it for what it is, but I wanted to make sure that you guys had this information. Last question here, sir. Well, we can go very, very quickly on this one.
You know what, Chris, the polls take about a minute, and I think people are enjoying your lecture, so we'll skip the poll. There is a question that came in. It says, have you heard of Tagamet to treat zoster neuralgia very early on? Or I've heard Tagamet being used to treat just viruses. Do you want to just cover Tagamet and its off-label use?
Absolutely. So the H2 antagonist. So yeah, I have heard of that. I didn't put that in there. I think that's a really nice option, and especially when it's an over-the-counter medication like that at lower dosages. I think if the patient is compliant and is a good option for using a Tagamet, I think there's wonderful value in trying a Tagamet to reduce that viral impact of herpes. Because if anyone has ever had a herpetic outbreak, if anyone has ever been through that, virtually anything that you can do to reduce symptoms, to reduce duration, you're doing the right thing for that patient. So yes, I have heard of that, and I would support that. What I can do, sir, is
go ahead and take another 5 minutes and go ahead and go, and then we'll wrap her up.
Absolutely. I'll go real fast on this one. So this one, just want to talk about central serous. So there's a number of different off labels on this one. It's going to be in your handouts, so you can hang on to this one, but I wanted to get to the actual case study. So it's rifampin is what we use. So oral rifampin for central serous chorioretinopathy was relatively new to me. I had not utilized that before, but really what rifampin does, rifampin helps mitigate some of the endogenous cortisol within the system. And a lot of central serous chorioretinopathy, it's all about the endogenous cortisol. If you can get the endogenous cortisol down, that's going to make all the difference. And I'll just show you a real quick case report. I can do it in 2 minutes. So this is a flyer in Japan. Can't get him off the island. It's Christmas. You can see that Amsler grid not so good, and everything's looking a little funky. Macula, significant elevation. When I said significant elevation, it's tough to really appreciate it here because it's in 2 dimensions, but you can see the distortion on that right eye. And here we go. That was probably one of the bigger CSCs that I saw just like walk in on my own, because that thing was huge. We had 1,000 microns of thickness on that bad boy. So this is walking in on day 1. Here you can see that some of the 5-line rasters, just the size and scope of the central serous. Visual acuity impacted, but not nearly as impacted as you might think for the appearance. So again, Murphy's Law, both ophthalmologists were off the island. Like, of course they are. Why wouldn't they both be out there? So then I had to call someone in Hawaii, and Hawaii is like, oh, he just happened to be a retinal specialist. He's like, hey, I've done this before. Try some rifampin, check with the PCP, make sure the flyer can take it. 300 milligrams BID for 30 days, follow-up Fenshi therapy. So it's tough to appreciate, but in 30 days, that's what it looked like. So if you've ever had a CSC patient, they don't typically resolve that cleanly and that nicely in such a short time. And this is 30 days only because he was told 30 days. He said that he could notice changes within the first 10 to 14 days. So I almost wish we'd have forced him to come back at weekly intervals so he could have seen a progression. But I put that out there because oral rifampin, it's all about the endogenous cortisol. That might be a real option for all of us that see CSC or central serous chorioretinopathy on a regular basis. So here we are at the very end. Apologize, I got to go real fast. Here's some off-label medications that become on-label. So I think everybody's seen the new Vuity, pilocarpine at a relatively low percentage. And you can see what it does. So this is FDA approved now. Lumify, which was brought up earlier, a very low percentage, but you can see that this was an off-label that became on-label. And Upneek, so oxymetazoline, so that same type of lift in the lid. So it's a direct acting, relatively selective alpha-1 adrenergic agonist that targets Mueller's muscle. So this is this is a prescription treatment for that same type of thing we talked about with aproclonidine. And here we are with Latisse. So these are essentially off-label medications that were discovered that became on-label once they went through the FDA process. So here is kind of the culmination. This is for everyone to read at the end. So if you want, there is the actual dosages, there's the concentrations, and there's the durations from a meta-analyses point. So this is from all the studies I could find, kind of putting them all together. Here's kind of the prescribed, if you will, using the prescribed word, treatment for all of these different conditions. So these are all available online. You can have OEC send out all my slides. They're absolutely open source. Take a peek at those, but you can see Pred Forte, so diabetic macular edema, cystoid macular edema, retinal vein occlusion from an ischemic standpoint. You can see the Pred Forte with the COSOPT for NVD, neovascular and macular holes, and then HSV stromal keratitis, mild aproclonidine. I won't read them all out there, but they're all on your slides, and they're all have the dosages there for you. And then the last one here's the off-label use at the very end. So atorvastatin, prednisone, metformin, lisinopril, and then spironolactone, rifampin. That is for the central serous chorioretinopathy. And then here are the supplements at the end. So I think these last 4 slides, they take 2 hours that we just chatted, and I put them all into 4 slides. So really, if you want to reference, I put the double asterisks on the bottom because I can't find peer-reviewed, and I promise you peer-reviewed. Everything else has peer-reviewed literature that has a evidence-based practice basis. So limitations, obviously there's always going to be some limitations, off-label care, but it's really the opportunity. Meaningful medical treatment between referral and specialist follow-up. There's shortened duration and severity. You can reduce the need for more invasive therapies, and the PCMT mean is the take-home. This is where primary care needs to stick together. Primary care, systemic and primary care optometry, I think there is value for us to be on the same team. Evidence-based off-label therapy, I think that's probably what's next. You can see the off-label algorithms just determine what the clinical findings are, drug classage, and I think in an algorithm like a Bayesian equation to identify what's most effective. We won't do the medication use, but here's the last one. This is free. It's open to everybody, Cochrane.org. This is where the meta-analysis and the systematic reviews are found. You go on, you type in optometry ophthalmology, and boom, it's got paid nerds on their end that their whole job, their whole reason for being is to take all of that peer-reviewed literature and distill it down to give you, the clinician, you, the practitioner, the gotta know. And it's got everything from convergence insufficiency all the way up to exudative diabetic maculopathy. So it covers all of them, and it's free to you. You can sort it tonight if you want, or tomorrow morning. But I think this is really your go-to. That is where you need to start. And then this is one of my favorite books, Wisdom of Crowds. In fact, it's far better to have a whole bunch of people with different backgrounds than a whole bunch of people with the same background, because you eliminate biases. We're all trained the same way, so we have the same blind spots. You will get better solutions by having individuals with slightly different backgrounds that see the world differently. So I think that quote from Sirwicki is one of my favorites. And with that, I went very fast at the end, but that is all I have for everyone here tonight. Any questions at all?
Nothing has rolled in here, Chris. So the last one was regarding the Tagamet and Zoster. Went a little bit longer than usual, but it was good information. Yep. So I'm going to just say thank you for your service. We appreciate you being here tonight. It's now 4 a.m. your time. And thank you for your service there in Qatar. And with that being said, thank you for doing clinical potpourri off-label medications with clinical optometric implications. Thank you very much. You're getting your virtual round of applause in there. If you turn in your chat, you'll see you're getting terrific and thank yous, your virtual round of applause. Thank you very much. I'm going to end the CE at this time.
Outstanding.